My name is Ryan Hidalgo. I'm happy to be here and I'm honored to be invited to give a talk today on contemporary trends in the evaluation and management of pelvic organ prolapse. Um, Pelvic organ prolapse, or POP, or POP, as I will refer to it all interchangeably today, is a very common condition that, of course, since the establishment or the formalization of our field in 2011, has become kind of like a bread and butter thing for us urogynecologists. However, I chose to talk about this today because I feel it's very, very important for anybody who takes care of women, which is basically everybody, to be aware of this diagnosis and to be aware of the general management trends. Um, I should go ahead and start by saying that I have no disclosures, but learning objectives. There are whole textbooks and journals dedicated to the reporting and the study of pelvic organ prolapse. I'm not necessarily going to rehash all that. Instead, I want to distill it to a few common objectives. Number one, I'd like everybody in the audience to be able to identify common presentations of pelvic organ prolapse. I'd like for everybody to be able to summarize management options for pelvic organ prolapse, non-surgical and surgical. And then more importantly, to kind of discuss or to be familiar with the more recent trends in the management of pelvic organ prolapse, especially since patients will almost undoubtedly be coming to you, and if they have a complaint of prolapse, may be aware of this through other literature and other media. And so I want to make sure that we're all aware of that. Now, one thing that is not a learning objective, but I think is fun at least, is a little bit of history. Prolapse is as old as time immemorial. It was first recorded in these Egyptian gynecologic papers or papyrus back in the 2000 before the Common Era. It was a little bit crude. They described rubbing feces and petroleum on women to try to get the prolapse to come back. They did not report on their outcomes. But later, Hippocrates, several centuries later, had decided that the uterus was an animal unto itself and advanced the technique by saying, no, let's put the astringent directly on the uterus because maybe it'll crawl back up. I'm not making this up. And use things like toxic fumes to try to have the uterus to come back up. They described something called succussion, where they would hang women upside down until the prolapse was reduced, then tie them to a bed with their legs together to keep the prolapse in. A couple more centuries later, Soranus of the Ephesian, who was one of gynecology's most famous in antiquity, was like, maybe not so much that. Maybe if we make like specially designed tampons and other things that can go in the vagina, maybe that will hold up prolapse. And that went on for like thousands of years, basically. Until interestingly, this male midwife, Percival Willoughby, in the 17th century, reported on this woman, a peasant woman named Faith Raworth, who apparently had prolapse, was so bothered by it that she took a knife to herself and performed autosurgery, one of the first examples of autosurgery, and did a vaginal hysterectomy. She lived to tell the tale, at least to this Willoughby person. And he wrote it up. Unfortunately, she suffered from stress urinary incontinence for the rest of her life. I cannot imagine why. So with that kind of thought in mind, from the 1800s to today, the diagnosis and management of pelvic organ prolapse has been refined, to say the least. So anyway, to the actual presentation, to identify common presentations of pelvic organ prolapse. In short, pelvic organ prolapse is a herniation of the pelvic organs through the vagina. This can be described by patient symptoms. They may say that they see or feel a vaginal bulge. They may feel pelvic pressure. They may have pain either with intercourse or without intercourse. Many times women will say, I feel like I'm sitting on something. And we'll typically ask women like, they'll say something like, I feel like I'm sitting on an egg or a grapefruit or something. They may also have compartment-specific symptoms, compartment meaning the different organs of the pelvis. They may have bladder symptoms like incomplete voiding or urinary retention, difficulty starting their stream. They may have a hard time with defecating. They may need to splint. Splinting is a phenomenon where women, especially if you ask them, do you have to use a finger and insert into the vagina in order to push something back so you can have a bowel movement? Many women won't bring that up, but if you ask them, they may admit to that. And then apical, or like the top of the vagina, they may describe vaginal bleeding, and when you look inside, you just see this irritation of the vagina. Like everything else too, there's the subjective complaints, but there's also objective complaints. The ICS, or the International Continence Society, defines it as descent or one or more of the anterior, posterior, uterus, or apex of the vagina. I write cystocele and rectocele because they're classic terms that we use to kind of describe those compartments. I do add bladder and rectum in quotes because I would like everybody in the audience to be aware of misnomers. A rectocele is the herniation of the rectum into the vagina, pushing the vagina out. It is not rectal prolapse, which is the circumferential prolapse of the rectum. patients may be perhaps confused or misinformed, or maybe read something and aren't communicating it exactly well, or even well-intentioned providers may have told the patient correctly that they have a rectocele, but then what the patient heard and understood was rectal prolapse. So again, pelvic organ prolapse is herniation of the vagina to the surrounding structures. Moving through this is just a quick schematic of normal female pelvic anatomy in a sagittal view. What I want to point out here, hopefully my laser pointer works, is that here's the vagina, of course. Here is the vesicovaginal septum. Here's the rectovaginal septum. I show you this because the next few images or slides show MRIs that match this image. So here's an example of anterior predominant prolapse. At first glance, you may look at this and be like, oh, I don't know, it doesn't look like the posterior. But when one does an examination, which I'll talk about later, you find that it's actually an anterior prolapse. This MRI, the weighting shows the fluid in the bladder, of course, and though you don't necessarily need to get imaging to diagnose prolapse, I just want to point out that this is for illustrative purposes. This shows that it is, in fact, the bladder that is herniating through the vagina. Here's an example of posterior predominant prolapse. The bladder appears intact. However, the rectum, outlined in brown, is pushing forward or anteriorly and down into the vagina and causing this. Here's an example of somewhat dramatic apical predominant prolapse. In this case, clinically, one may not be able to tell what exactly this is. This woman doesn't have a uterus, and upon further investigation, one would find that this is actually a herniation of the small intestine, creating an enterocele, which is basically a hernia of the peritoneum coming through the cuff, or where the cuff was, or rather the cervix was, and pushing down and out. This barely visible green line right here illustrates what the peritoneum is herniating through. And then finally, you can also have uterine prosyndengea or complete prolapse. That's when the uterus itself and cervix descend down through the vagina. And here is like a very classic example. Perhaps this is what Faith Ballworth had, and that's why she decided to do this to herself. So how common is this? Lots of studies, but basically anywhere between 3 and 12% or 11% of women describe symptoms only. But interestingly, a reanalysis of the Women's Health Initiative, the WHI study, showed that up to 41% of women had some type of prolapse, period, whether or not that they were symptomatic. So 41%. They had found that after pregnancy and delivery, up to 31% of women had stage 2 prolapse. Not necessarily that they're symptomatic, but that it was there. However, the peak incidence of symptoms that women are bothered by this is in women aged 70 to 79 years. Because of this, and because of the rapid, the aging of our population in general, it's anticipated the number of women experiencing pelvic organ prolapse will increase by 50% by 2050. And that women in the United States have a 13% lifetime risk of undergoing surgery for prolapse. So point is that if you take care of women, there's a very, very high likelihood that you're going to encounter a woman with prolapse, at least objectively, and maybe and probably even subjectively. So what kind of risk factors do we have to look out for? I mentioned it already, but the big one in the room, of course, is pregnancy. Notice that I say pregnancy and not delivery, irrespective of the route of delivery, pregnancy itself, because of the massive changes and the incredible changes in the female pelvis, that can predispose to injury. But certainly if there is macrosomia or prolonged labor, trauma, operative vaginal delivery, these are all things that have been associated with increased rates. Anything that increases intra-abdominal pressure. So we're talking about obesity, chronic constipation, even chronic pulmonary disease like COPD or emphysema. People who have a lot of gravity pushing down on the pelvic floor, or augmented by coughing and like these big fits, that can predispose to prolapse. And then anything that alters tissue strength. So we're talking about pelvic surgery, age, and just the change in tissue. And then some of the more exotic ones are things like collagen disorders and other things like that. So physiology, I'm going to run through this somewhat quickly, but there is it's essentially a combination of ligamentous support or connective tissue support and the tonic support of the pelvic floor muscles. Now, back in 1992, Dr. John Delancey, who's one of the kind of preeminent anatomists and urogynecologists of our era, described 3 levels of support, 1 being the most superior and 3 being the most inferior. Level 1 is the apical support. This is classically your cardinal and your uterosacral ligaments kind of holding up the top of the the uterus and the cervix. Level 2 is lateral support. This is kind of like I imagine like you're hanging a tarp, and so the level 1's holding up this way. Level 2 is the lateral supports, the arcus tendineus fascia pelvis, which is a condensation of connective tissue in the pelvis. It's readily seen on surgery if you would ever see it. And these are these paravaginal attachments. And then level 3 is inferior support connecting to the perineal membrane and the perineal body. Again, imagining that kind of tarp. If there is a tear in any of the things of the tarp, you may have some sagging or you can have some weakness that jeopardizes the integrity of the entire system. As I mentioned, the intact uterosacrum cardinal ligaments are the level 1 support. And the idea is that it actually pulls the cervix and the vaginal apex towards the hollow of the sacrum, and it positions the pelvic organs over what's called the levator plate. So I'm going to get the picture soon, but the levator plate is basically a condensation of the levator ani muscle complex, the two bilateral sides in the midline. As a reminder, iliococcygeus, pubococcygeus, puborectalis. These muscles have both a tonic, or like a kind of involuntary tone, but then also a voluntary squeeze that both help to close the urogenital hiatus and help to maintain that horizontal positioning. Here's a picture that I promised with a couple of highlights that I talked about with the pelvic floor. This is like looking down into the pelvis as if during a hysterectomy or like a C-section or something. Not pictured here is the puborectalis, but the idea is that there's a urethra, a vagina, and a rectum. The pelvic floor needs to support the pelvic organs, but they still have to be able to accommodate things like urine passage, or passage of a baby, or intercourse, or passage of stool, but then close back up in order to not allow it to fall through. That's what the role of these muscles are, and failure of any of these can predispose to the organs falling out through the hole that is typically closed with a tonic contraction. This is also just a neat image of a reconstruction from MRI, just to show that, when we look at textbooks, we look at the pelvis like it's like a fish bowl or something, like some sort of big fruit bowl. But in actuality, when there's normal tonic contraction of the pelvic floor, it's more of this kind of like biconcave or this butterfly shape, which is very intricate, and it helps to support the tissues in a supportive way. So then it naturally leads to that the pathophysiology may be that if any of these mechanisms are disrupted, the ligaments or the muscles, it can potentially position the pelvic organs over that genital hiatus and then predispose it to falling out. I'm personally partial to this boat in dry dock analogy. Basically, the ship is the vagina and the uterus. The water are the levator ani muscles, and the lines are the ligaments. Imagine that you're looking at the Seddon Channel and you see a ship in the channel. The primary thing keeping the boat from hitting the ship from hitting the bottom of the channel is the water, which is the levator muscles. The lines that are attached to the ship help to stabilize it from shifts from left to right or up and down. If, for example, the water level falls, which is like weakness of the pelvic floor, or if the water level rises, and that's the like hypertonicity of the levator. If there's some sort of catastrophic failure of the water, i.e. the levator muscles, and the water drops, the lines are there and can theoretically hold the ship for a little while, but they were never designed for that purpose. And so eventually the ship's going to bottom out in the channel. Same too, the levator muscles are the primary force that's holding up and supporting the pelvic floor. And, one may have an injury or one may have surgery, but then as long as the muscles are rehabilitated and maintained or restored to their natural or their tonic contraction, that's fine. But if there's a lack of that normal support, the ligaments can only hold on so long until eventually they either stretch or break, and then you prolapse, which we'll get to. That's where kind of, that's how our management strategies are kind of organized. So very quickly, diagnosis, you can diagnose it in dorsal lithotomy, supine, recumbent, standing. The idea, though, is you ideally need to get the patient to demonstrate the prolapse that they're talking about. So if they're laying back and you don't see prolapse, it's not like, oh, no, you're wrong, like you don't prolapse. We have them stand up, we have them cough, we have them strain, we have them do whatever it is. Maybe they garden and they're like, oh, whenever I squat down to go put potting soil in, we have them squat and we look and we examine to see, and sure enough, there's usually some demonstration of that prolapse. It's important to use a split speculum in order to assess each compartment independently. This didn't reproduce very well in the image, but basically, if there's concurrent apical, anterior, and posterior prolapse, you take the speculum apart and you use only one side in order to identify each one, and you evaluate them, or you document that accordingly. So you've diagnosed prolapse, and now you want to tell your colleagues or whatever. How do you do that? So A traditional or a classical way of doing this is what's called Baden-Walker grading, or the halfway system. It was first introduced by Baden and Walker back in the late 60s, and basically was a way to, going back to the compartments, talk about the bladder, the apex, and the posterior. And they would say, for example, that 0 is like no prolapse, 2 was down to the level of the hymen, 4 was maximum descent, and then 1 and 3 are basically somewhere in between. The way that this would be described is you would look at the front or the anterior, you'd say, oh, she has a grade 3 cystocele, a grade 2 rectocele, and let's say grade 2 apical prolapse, which is fine. It's better than just being like, she has prolapse. However, it's not always as reproducible. It is a bit subjective because there's, more than just halfway, of course. And for that reason, POPQ, the pelvic organ prolapse quantification system, was designed. Now, I know like the residents especially are probably like getting nervous, like, oh my God, look at all the like numbers. I'm not going to like go through like exactly how to interpret this. Suffice to say that this is something that was developed in 1996. And the idea was, especially as our field began to develop, we needed a way to reliably and in a validated fashion present or document what we see, and then more importantly, as we do initiate investing or intervention, make sure that we're attaining the goals that we need to. So just at quick glance, you can kind of see, I'm not going to get into the weeds of it, but basically stage 0 through stage 4, these are stages, not grades, but they closely mimic the grades. Stage 0, I joke with patients, is like a newborn baby girl. Stage 4 is Faith Raworth. And then stage 2 is like at the level of the hymen. But then the stages in between, there's like a lot of granularity and all these formulas about like how much it is. For the clinician, it's just, it's, don't worry about interpreting this, but just to say that if you see a grid like this, basically these numbers show 1 point that's 3 centimeters proximal to the hymen or the urethral meatus. These numbers show whatever the most distal or the most prolapse part are, and these denote the cervix and the posterior fornix. Negative numbers mean they're inside or proximal to the hymen. Positive numbers mean they're past the hymen. So negative numbers are good or better, and positive are not as good. And then these numbers are basically a measure of the general hiatus, the perineal body, and the total vaginal length. In case you're ever in like an emergency, like POPQ situation, there is a wonderful app. There's an app for everything by the American Urogynecologic Society. Unfortunately, sorry, Android folks, but they don't have it yet. But there's an app where you can basically plug in all the POPQ numbers, and the schematic, which you probably recognize from earlier in the presentation, will actually dynamically change to show what part is prolapsing. And it helps not only for providers, it used to help me when I was a resident to kind of visualize what's happening, but it's great for patients who like, no, this is like what you are seeing or what you're feeling. So that's that. So you've seen it, you've documented it. Now you want to talk about management strategies. The big important part about urogynecology is that we focus on quality of life and patient-centered outcomes, which is basically to say that with very few exceptions, women are generally not like actively dying from their prolapse, but it is typically very uncomfortable, and it's something that can be addressed and needs to be addressed. But the big question is it bothersome? I mentioned earlier that 41% of women may have prolapse, but only the 2 to 12% report symptoms. For the rest of those women, if you happen to notice it as a provider, if they don't bring it up, you might not even necessarily have to, you can point it out, but you just tell them if it's not bothersome, then we can continue watching. But I'll get to that. If it is bothersome, you ask them, what are your therapeutic goals, or what would you like how far would you like to go to treat this? That will help you to determine whether you go proceed with expectant management, conservative management, or if needed, the surgical management, which is the segue into my next part. So the first part is non-surgical management of symptomatic prolapse. Good news is that our studies of natural history have shown that most women who decline treatment for prolapse will have no change, or maybe only a very small increase in their POP over subsequent years. So you can safely tell patients that. Even if mildly symptomatic, it's reasonable to initially proceed with only expectant management. Intervention is only warranted for people who become sufficiently bothered enough by their pelvic organ prolapse, which of course may change over time. But the important part is to be clear about the diagnosis and to reassure patients of your findings. I mentioned earlier to beware of misnomers. Please don't tell patients that their rectum's falling out, because that's like a completely different thing. They're going to go home, WebMD it, and be like, oh my goodness, I need to, whatever. Other thing too is a lot of women just don't know what's happening. They just feel something down there, and people tell me, I was just concerned that it was malignancy or cancer, or I just didn't know what it was. Assuming that when you look in that you don't see it. It's something that is, something that is not, uh, it's not uncommon, that it may not necessarily be anything of concern unless it bothers them. And I sometimes even say, especially when the patient's like, oh, I was just afraid it was cancer, I say, this does not appear to be cancer. Obviously, if they have continued symptoms or other things, you have to continue to investigate that. But at least for the prolapse side, I like to reassure them. So maybe they don't want to do nothing, they want to do something. So there's pelvic floor muscle training. At this point, Dr. Arnold Kegel is like a household name, like everybody and their sister and many brothers like talk about Dr. Kegel, and oh yeah, like I saw a TikTok about Kegels, and like I'm gonna do Kegels. So the idea is that patients can be taught to identify, isolate, and contract and relax pelvic floor muscles selectively. This is the water again. This is like that tonic contraction. If the contractions are weak and it's straining the lines or the ligaments, then it makes sense to strengthen the muscles. The important thing, or so the way a lot of women have been told, or we even try to kind of explain, is to lift the pelvic floor or to stop your urine stream. The important part, though, is I joke that it's kind of like if somebody wants to do, get into exercise. So you're like, I'm going to do 500 crunches and 500 push-ups tonight at home. You could theoretically do that. You're working out some muscles, but you might be exercising the wrong muscles. So at the best case scenario, you might be developing bad habits. At the worst case scenario, you might develop strains, or you might actually cause other issues with the pelvic floor if you are not contracting the correct ones. So if only there was like a personal trainer type kind of thing for women. Funny enough, there is a whole field dedicated called pelvic floor physical therapy, whose like entire purpose is for exactly this thing. It's a combined regimen of behavioral and physical therapy that has been shown to have a beneficial effect on muscle function, prolapse symptom, et cetera, et cetera. These are all masters and doctors of physical therapy who have chosen after physical therapy school to basically undergo advanced training, either a residency or other selected courses, to do specifically these maneuvers. They work with patients to identify these muscles, often through internal mechanisms, and help to strengthen them. But they also look at the patient as a whole, and they say, oh, like, that's interesting, your gait is a little bit off. Like, let's see, like maybe your hip flexors are off. And funny enough, everything's connected. And they can find things that may be referring to pelvic pain or pressure, but are actually a more orthopedic or like musculoskeletal issue. They can also help with something called biofeedback, which is basically a way that patients can learn if they're contracting the right muscles immediately. So in this image, this shows like one example, somewhat more kind of like scientific or whatever example of, there's a probe in the vagina, and when the woman contracts, it shows a deflection in this graph, and then it kind of reduces. But if it there can be images that can show like a flower blossoming or whatever. The point is that it shows the woman that she is contracting the proper muscles. Pelvic floor PT is great, and I recommend it as a part of initial management for most, if not all, patients who can do it. However, it does require active motivation or active participation of a motivated patient. And it's really important to communicate realistic expectations before you send patients there. It's great, again, going back to the water in the ship, if the water level's low, you can kind of like raise the water before there's too much tension on the lines. However, if the water's been gone for decades and the ship is already like laying on the ground, then like, frankly, like, you're going to have to address the other structural components too. But at the same time, some patients may be kind of hesitant about going to pelvic floor PT, as long as patients are aware that they don't just show up and then they start doing internal maneuvers. They get to know the patient. They talk about the kind of like their gait issues. They diagnose everything. And then once the patient is ready and willing, more especially, to have that sort of intervention, they can move on to it. And I'll get to this later, but we have plenty of resources here at USF now and throughout the area. Moving on. Pessaries. So mysterious devices to some people, but they're really just devices that are inserted into the vagina and they hold up prolapse. Here's the history nerd coming out again in me. Remember Hippocrates and yeah, so they use like beeswax and pomegranates and things up there. But nowadays we just use silicone. It's easier. So we fit it to the vagina specifically. It can actually be used for both prolapse and stress urinary incontinence. And it's my opinion that women considering any treatment, especially surgery, should at least be brought up to the idea of a pessary because it can be quite successful. In fact, up to 92% of women can be fitted successfully with a pessary. I won't get to this too much, but basically the ring pessaries, these pessaries or these pessaries work best with patients with like less severe prolapse, stage 2, stage 3. But the more exotic ones like Gellhorns, which are shaped like pawns, like chess pieces, and Q pessaries, they're more for like stage 3, like advanced, and stage 4. It's often trial and error. Usually we end up just measuring with our, like a digital examination of the width and the length and the height of the vagina, and we find a pessary that matches those dimensions. Though here at our own institution, we've kind of found that using GH measurement is a pretty good way to kind of like a rough estimate. So like a GH of 3, maybe try a ring number 3 size. But again, trial and error. It's important to maintain the pessary. We usually see patients every 3, even up to 6 months now, but we always have to watch out for damage to the vaginal epithelium. It is a foreign body after all. If a woman has vaginal atrophy, it's strongly recommended to treat it before pessary use and during. It can be a cream, ring, or a suppository form. And then if a woman describes discharge or definitely bleeding, then you want to be able to take out the pessary, look inside, make sure that there's not an erosion or anything like that. And if there is, to manage it, or if there's an infection, to manage it. Serious complications are very, very rare as long as the patient maintains at least some form of follow-up, ideally regular follow-up. But the kind of like the big scary ones that we always worried about are rectovaginal and vesicovaginal fistula, and that's like when patients forget about it for like years or decades. So don't do that. Now I'm going to very quickly run through the surgical management of pelvic organ prolapse. Again, I'm not looking to make everybody experts on how to do it, but I just want people to be aware of kind of what are the options that we can offer, especially since patients may come and ask specifically about certain ones. So the general types of reconstructive pelvic surgery. There is obliterative surgery. That is like, close up shop, like, you can't have something fall through a hole if there's no hole. So that's basically obliterative surgery. And then reconstructive surgery is the where we try to restore normal pelvic support and anatomy. We'll start with obliterative. It represents about 5% of women in the US undergoing POP surgery. We typically reserve it for the elderly or the very medically compromised who are willing to sacrifice penetrative vaginal intercourse. And so, you tell them like you will not be able to accommodate anything in the vagina afterwards. But it has a quick recovery, low morbidity, very high success rates, like 95% or even higher. And surprisingly, the literature has shown that women who have been properly counseled have a very low risk of regret. So, you think about your woman who's like 88 years old with like congenital heart failure or something, and you're like, I don't really want to like do too much stuff, but you want to give her back at least, some quality of life. This would be an ideal procedure. Colpocolysis is the classic one, initially described by Lefort. This is a partial colpocolysis, meaning the uterus is kept in. So obviously the patients have to have a uterus. They're no longer sexually active. Importantly, we do not offer this to women who have postmenopausal bleeding or other uterine pathology until it is evaluated and managed if necessary. It makes it very difficult to evaluate the endometrium if you can't get to it anymore through the vagina. The great thing about this is it can be performed using general or even regional anesthesia like we've done here before. Again, the women who are very, very ill and can't undergo general anesthesia. And then the ideal patient is somebody who has like that, Faith Raworth level, like it's all the way out type prolapse. And then we usually combine it with a posterior repair and a perinorrhaphy, which I'll get to later, to close the general hiatus even more. So here's what it looks like. Here's the before, here's the during, and here's an after. Contrary to popular belief, it's not like, it's not completely closed. There is still a small amount of vagina, usually like 3 or so centimeters. But we caution patients that it's not designed to accommodate intercourse. And then there's also colpectomy and colpocolysis. This is a way that we can remove all or most of the vaginal epithelium. This is great for women who have post-hysterectomy prolapse, and or it can be done at the same time as a vaginal hysterectomy if that is indicated. And that basically involves, denuding the entire vagina and reducing it and suturing it concentrically or sequentially. All right, moving on to reconstructive procedures. These are the ones that restore pelvic anatomy. Again, we're talking about those lines and those ligaments, and we're trying to get those back to where they were. And then hopefully afterwards, then address the support with the musculoskeletal system. This is an important thing I want to note. We can do all the surgery in the world, but if we don't address the other elements of support, the patient's motivation to have it done, and also, have like a realistic expectation with women on like to avoid risk factors, we worry about recurrence, but we'll get to that later. But the point of reconstructive procedures is we're putting back things the way they were. This can be done vaginally, abdominally, laparoscopically, robotically. We can use just native tissue, just your own tissue. We can use grafts. I'll start off with kind of some of the earliest or the more basic ones. Moving quickly through this, an anterior colporrhaphy or an anterior repair basically is plication or reattachment of the layer between the bladder and the vagina. I always kind of tell patients it's like making a dart in like tailoring. You're basically bringing in the tissue and you can fold it. Or if there's a tear of those level 2 supports, you can reattach the tarp, so to speak, to those lateral supports. That's what a paravaginal repair is. It has pretty good anatomic success. However, there is some asymptomatic anatomic recurrence, around 10%. Again, urogynecology, patient-centered outcomes. It's a bummer for us surgeons when we see like it coming down, but the important part is how do you feel like have you met your therapeutic goal? So that's one way. And then the symptomatic recurrences has been quoted around 5% within 2 to 3 years. Other side, posterior colporrhaphy. Basically same thing, but for the rectovaginal tissue. And a perinorrhaphy is where we reapproximate the perineal body in the midline to restrict the genital hiatus. This also has pretty good, or great actually, anatomic cure rates associated with some improvement in defecatory symptoms. However, it's important to counsel patients that it may not necessarily affect function of the bowel, though it is often found to help. Again, expectations and realities and managing expectations is important. We often will combine these two procedures in addition to some of the later stuff in case there is still residual prolapse based on after some other repairs. Moving to the apex, we can also reattach the top of the vagina or to the uterosacral ligament. This is an intraperitoneal approach, which can be done vaginally, abdominally, laparoscopically, or robotically. It's great because we can basically like do it at the same time as like other surgeries. Let's say there's other intra-abdominal pathology, can be done at the same time as a hysterectomy. And the mean objective success rate has been about 85% across several studies, with a mean operation rate of about 6%. An extraperitoneal approach is sacrospinous ligament fixation or suspension, same thing. Basically, instead of going through the abdomen, we go through the vagina, dissect beside the rectum and behind the peritoneum, and we attach the vagina to the sacrospinous ligament. It can work great, especially for these women who have already had a hysterectomy. We don't want to do an intraperitoneal procedure, but because of the way that the vagina is reattached, there is unfortunately some apical recurrence after sacrospinous ligament fixation. So that's just one thing to look out for. And then reoperation rates are, these are funny, like large ranges, but the short version is it's often less than 9%. It's like comparable. And in fact, one of the two of the big studies, like long-term studies in our field, have shown that both of them have comparable anatomic, quality of life, and reoperation outcomes. The point is if a woman decides that they want to have, or if it's most appropriate for her to have a native tissue repair, there are plenty of options. They can all be mixed and matched, and they have good outcomes that are comparable. Now we're getting to kind of like some more advanced stuff. There's sacrocolpopexy, which of course has become kind of like a hot topic lately. This is suspension of the vagina using a bridging graft to the anterior longitudinal ligament of the sacrum. This is an intraperitoneal repair. It can be performed open or laparoscopically with or without robotic assistance. And the ideal candidates are patients who have not enough vagina to do vaginal length, I should say, in order to do it vaginally or through one of the other approaches. You can't put together tissue that doesn't necessarily reach, or if they have a history of or increased risk of recurrent pelvic organ prolapse. Ideally, these are the patients who have tried a native tissue approach and have failed it, or there's been recurrence, or that sort of thing. Historically, lots of different things have been tried: fasciolata, rectus fascia. Modern materials are polypropylene, polyester, and polytetrafluoroethylene, or PTFE. But ultimately, the bottom line is that randomized controls trials have found that type 1 polypropylene mesh. So type 1 means they are this is getting to the weeds, but like macroporous materials, pore size greater than 75 micrometers, and monofilament. They are superior to using cadaveric fasciolata, and so that has become our gold standard for graft augmented repair. And this led, and I'll get to this later when I talk about it, but this led to a Cochrane review that concluded that in studying sacral colpopexy compared to vaginal approaches, it's associated with lower risk of awareness of prolapse, recurrent prolapse, repeat surgery for prolapse, that's an important part, postoperative incontinence and dyspareunia. But the trade-off is that it is an intra-abdominal approach that takes much longer than the other time and can increase cost. And because of the increased, the bigger surgery, so to speak, some women can have a longer time recovering. I'm going to kind of run through this quickly, but basically, there are lots of ways to do sacral colpopexy. In the modern era, it's been or contemporary, it's been a lot of laparoscopy and robotic assistance, which have been comparable, and the success rates range from 78 to 100%, which is great. Interestingly, there's a long-term trial that didn't specifically study this, but in our field, it did show, though, that the rate of mesh-related complications was as high as 10.5%. So this is an important thing to talk about with patients. We are now introducing a foreign body into the uterus, and into the abdomen, and we want to make sure that they are aware that we have to watch out for these complications, which may be a cause for reoperation in the future, especially if they are heavy cigarette smokers or tobacco users, or if you're taking out a lot of tissue, we have to worry about these sort of exposures. Bottom line is that careful patient selection and counseling are important for when considering this procedure. So identify the goals of therapy and treat accordingly. So here's a review, but that's not all. There are actually many more ways that we can treat prolapse, and especially in the past decade or so, there's been a resurgence of some recent trends in how we treat prolapse. Since I've been talking about sacral colpopexy and grafts and stuff, I do have to talk about the M word, which, of course, is mesh. It is not, it goes without saying that there has been a lot of publicity, lots of negative publicity, about transvaginal meshes, which I'm going to get to in a little bit. And so do not be surprised if a woman comes up to you and either brings it up directly, or I don't know, I can sometimes feel it in the room whenever I'm talking about repairs, and I'm just like, the patient's like waiting for me to say the M word, and I say mesh. And it's important to be compassionate and understanding, but also address the issues surrounding mesh with patients so that they can make an informed decision about which way they want to go. There are actually 3 mesh-based urogynecologic procedures. There's the abdominal mesh, so that's sacral colpopexy, the transvaginal mesh for incontinence, which is the sling, which is a whole nother topic and textbook altogether, and then the transvaginal mesh for pelvic organ prolapse. That is the one that all these FDA things are talking about that we need to discuss. So I don't want to bore everybody with all the history. Again, history nerd, but the short version is in the late 90s, first mesh for incontinence. In 2002, the FDA cleared the first mesh, transvaginal mesh, for prolapse. It was initially classified as a class 2 device. Without getting into all the weeds, basically it means that like once one was approved and accepted, then like other kits and companies could kind of follow suit and kind of use that precedent device and be like, okay, yeah, it's like similar enough, so they would be released to market. This exploded in popularity, and it was actually, it seemed like a very bright time for the management of pelvic organ prolapse, because lots of different providers all across the country could learn how to learn about these kits and to offer them to patients and to implant them in patients. By 2005, up to 70% of mesh augmented prolapse repair used what's called commercial mesh kit. So everything was all fine and dandy, but then there it is. Unfortunately, by 2008, there was the first kind of inklings of something not quite right with these vaginal mesh kits. The FDA first released saying, hey, there are some complications associated with transvaginal mesh, exposure, pain, contractures, that sort of thing. By 2011, the FDA was like, okay, like these are like not rare complications, like it's happening like maybe a little bit too much. And at this point, the FDA started conducting or requiring that products conduct post-market surveillance studies on these kits to make sure that they were still safe. You might start to see a correlation between the timelines in like 2011 and like all the studies I mentioned earlier, especially in 2016, same year as that Cochrane review. The FDA was like, yeah, this is like high risk. Like they reclassified them as class 3 devices. They said all manufacturers need to demonstrate acceptable long-term benefit compared to native tissue repair. So again, Cochrane review, they not only compared sacral colpopexy and vaginal stuff, they also looked at transvaginal mesh kits compared to other things. Some results were promising, but unfortunately it kind of did show that like, oh yeah, this is not good. Like there's a lot of complications. A lot of companies just decided to be like, you know what, never mind. Like they just pulled them off the market voluntarily. Importantly, none of this applied to mesh for SUI and for the sacrocolpopexy. And finally, the nail in the coffin, the last one was in 2019, the FDA ordered manufacturers of all remaining mesh kits to stop selling and distributing products in the USA. They are banned. And I tell patients that specifically that mesh kits, we do not use mesh kits. They are banned. They're not legal anymore. And they have been since 2019. So that leaves us with these two mesh-based urogynecologic procedures. Thankfully, sacrocolpopexy throughout these studies has still been shown to be an effective and safe form of mesh for repair. Same too for the midurethral slings. But unfortunately, the transvaginal mesh it works in other places. It does not work through that modality and has been pulled from the market. I should mention that it is theoretically still possible to cut your own mesh and place it transvaginally. However, this has been largely abandoned due to safer alternatives. By me mentioning this, I am not endorsing this practice. It is not part of our clinical practice, nothing like that. But in case you have a patient who's like, no, like my buddy Fran had a mesh placed 3 years ago. Well, but the numbers don't really match up or the dates don't match up. It is possible they, for very, very special cases and for patients who are counseled very, very, very strongly about what that entails with the placement of mesh, you may encounter that. No matter what, you need to consider the alternatives of native tissue versus mesh augmented and have a long conversation with patients, or refer them to us and we can have those conversations with them. The final thing I want to talk about is the idea in these last few minutes of uterine preservation in pelvic organ prolapse surgery. Traditionally, our prolapse surgeries involved hysterectomy, even though there was no specific uterine disease present. One of my prior mentors in residency used to tell patients it was like collateral damage, or the uterus just happened to be in the way of the repair, that sort of thing. I don't necessarily agree with that statement, but the idea is that traditionally these techniques involved removing the uterus. However, anatomic studies have demonstrated time and time again that the uterus itself is not the cause of the prolapse. We're talking about the lines. Yeah, you can take the ship out of the channel, but you still didn't fix the water issue or the structural things. Hysterectomy itself, in fact, even is a risk factor for prolapse formation. So there's been a recent renewal of interest for uterine preservation, specifically because now that we have better treatments or effective treatments for abnormal bleeding and fibroids and cervical dysplasia, there are less and less reasons to take out uteruses if the patient does not want that. There is historical precedent to uterine preservation. I already mentioned the lephorocolpocolysis. That was in the 1870s. That keeps the uterus in. The Manchester procedure was from around the same time, basically involved amputating the cervix and then reattaching the uterosacral ligaments to a higher position, and it resupported the uterus. Some even recent studies over in Scandinavia or Scandinavian countries have shown that they look back and they're like, actually, the Manchester procedure has pretty comparable outcomes compared to some of our native tissue stuff. So there's been some resurgence in thinking about that. However, anything that keeps the uterus in does potentially complicate further pregnancy and or cervical and endometrial sampling, as one might imagine. Also, all those surgeries that I mentioned earlier, all the native tissue, all the mesh-based ones, they can be adapted for uterine preservation. This is an area of active interest and study. All you have to do is go to any Urogyn conference, and there are videos and workshops and everything about how we can achieve this goal. So we can do laparoscopic or transvaginal urosacral ligament hysteropexies, transvaginal sacrospinous ligament hysteropexies, and then there are even some future considerations of other methods like laparoscopic ventral suspension, where the uterus is attached to the front wall, or even open or laparoscopic sacrohysteropexy. So that's what this is kind of showing. This is just one of many ideas of using different sheets of mesh to encircle the uterus and cervix and to support it. Unfortunately, the evidence is still limited, but it suggests relative safety and efficacy. Big slide, big table, but what I want to point out here basically is who would a uterine preservation procedure be best for? It's great because there's a reduction in surgical time. There's an avoidance of a potentially unnecessary procedure. It's less invasive, less blood loss. Importantly, patient preference. Again, patient-centric outcomes and goals of care. If they want to keep their uterus, that should be an option. That should be something that is a part of the counseling. However, some of the disadvantages, it's still something that we're still working on. Maintenance of fertility is both a plus or a minus because you have a uterus, so you can still get pregnant if you're premenopausal. There's still that small but ongoing risk of cervical endometrial cancer. And as I mentioned, keeping the uterus in after prolapse repair may make it difficult to sample that. And then that's basically that. So in our practice, I kind of see this like bimodal kind of distribution thing. As more women get more interested in repair, or they're more aware of the prolapse younger, you may have a premenopausal reproductive age woman who wants to keep their uterus because they may want to continue childbearing. They're healthy, they may be like a good candidate for keeping the uterus. On the other side, you have your very, very sick women who are like in their 90s, and you don't really want to go through like a big intra-abdominal procedure, or maybe they have had like 19 surgeries in their abdomen, and like, I don't know if I can get that uterus out safely without harming the patient. These are the sort of patients where perhaps uterine preservation is promising. And indeed, this is something that we are actively incorporating into our clinical practice here at USF. So in my final few minutes of the presentation, how can we help you and your patients? As I mentioned, this is something that all people should be aware of, all providers for women should be aware of. But we are happy to be specialists in this field to help out with patients. I did mention the physical therapists. We are very, very, very lucky to have Dr. Terrence, Dr. Samori, and Dr. Kriz here, both at the MUMA Center, 5th floor, and also at Morsani. They are very experienced providers from the community who we are lucky to have here at USF now. So they're very, very easy referrals. I've had the opportunity to work with them clinically with patients, and I can assure you that they will provide you, your patient, with very comprehensive and very compassionate care. I joke that they're magicians. They just magically fix sometimes some of these things. And then, of course, I'm happy to present our division, our new USF division of urogynecology. We had met Dr. Prolapse, of course, earlier. She's nationally recognized and brings a wealth of experience from all over the country, and she's been leading our division and our fellowship in a very new and exciting direction. So thank you for that, Dr. Prolapse. Dr. Kathy Lynch requires very little introduction, but she was one of the first to obtain board certification in urogynecology, and she has been instrumental in the last few months as we transition into our new department. And we're excited for her to continue to be part of our clinical activities and our fellowship. Dr. Stuart Hart is one of the OGs, the original gynecologists of our department. He, was part of the formation of our fellowship, and he still has a kind of like an adjunct role you may see him from time to time. And I'm happy to introduce Sarah Frisco, who is our nurse practitioner, who joined us recently and will also be helping out with seeing our patients, providing the care. And as mentioned earlier, or alluded to earlier, I'm happy to finally officially announce that I will be joining the division. Thank you, everybody. Thank you. Joining division later on in the summer after I complete my fellowship. I also want to specifically mention my co-fellows, Araba and Ali. They've been very, very wonderful and patient colleagues, and even better friends as we go through kind of everything that we've developed over these past few months and going forward. I'm very, very excited. And with that, I'm happy to answer any other questions or discuss anything.
Yeah. Okay, that's okay. We'll project. Dr. Hidalgo, thank you so much. It was an excellent presentation. Thank you. I have a couple questions from the chat regarding, this is from Nevin, regarding thoughts on prevention. What are the thoughts of including pelvic floor PT as part of pregnancy and postpartum, like routine care? I had the same question. I wrote it down while you were talking. Like, should every woman who delivers get referred to pelvic floor physical therapy? What are your thoughts?
Yes, so disclaimer, soapbox.
Just repeat the question.
Yes, the question was, should pelvic floor physical therapy or pelvic floor exercises be part of routine prophylactic or preventative care following pregnancy and delivery? The short answer is a resounding yes. I do feel that we here in the United States are perhaps a little bit behind, for example, Europe and other countries where pelvic floor physical therapy is just a thing that happens as part of peripartum and even antepartum care. So the short answer is yes. That is something that, our division, we are actively investigating and interested in kind of discussing with our patients. And as we see more and more women who are in their reproductive years, we certainly bring that up to them.
And I have another question. If you, in your ship model, your ship analogy, the lines, the water, the ship, what if there's no ship? You mentioned in briefly in your slide, like that hysterectomy is a risk factor for, prolapse. I counsel patients all the time about, they're on the fence about, should I have hysterectomy, should I not? What should my counseling be as a gynecologist, for what should they expect? What is their likelihood of developing issues with prolapse?
Sure. And the question was, in the ship model, what if there's no ship? What if there's like no uterus? And what is the relationship between the development of prolapse and hysterectomy? It's important to counsel patients, individually on all of these issues. Unfortunately, the ship model kind of like falls apart when there's no uterus. But the point is that if there is a weakness of the pelvic floor and a woman, I'm making up an example. Let's say there's a woman who has a poor pelvic floor tone, or has some sort of like structural or collagen abnormality, and you perform a hysterectomy. I would counsel patients that, there is a possibility that the genital hiatus may not have sufficient tonic closure, and you may develop an interstitial or a vaginal vault prolapse afterwards. This is also something that, of course, as we can talk about, one-on-one or as clinicians, but there are also ways that we can discuss how to, with surgical techniques, that sort of thing, to prevent the development of further prolapse at the time of hysterectomy, with support of like to kind of prophylactically, so to speak, protect that general hiatus. So that's like a McCall-Coldoplasty, for example, at the time of vaginal hysterectomy, or tagging the uterosacral ligaments to the cuff. But again, the answer to the question, you have to take each patient into consideration. Certainly, I would not have that be a dissuading factor for women who has an indication for a hysterectomy, but it's an important consideration.
We're gonna have to stop there. We've got folks waiting. That's one drawback of being here in person, is that these people love this room and they want to use it. So we're gonna have to wrap it up there. But thank you so much.
Thank you, everybody.
Appreciate it. All right, we gotta everyone up. Head to the door.
Yeah.